Good afternoon. We have with us Dr. Rajeshri Roy, Critical Care in Charge at Amri Hospital, Salt Lake, Kolkata. We welcome you to the Natco Pharma Specialty Studio this afternoon. We look forward to listening to your advice to the young generation doctors in the space of healthcare and bacterial resistant treatments. Uh, as for you, Doctor, how do you foresee the changes in critical care management?
First of all, the main issue is that we are coming across of all the resistance bug in our ICU. Whatever the people are coming with a stroke and they develop cowpenimus resistance. That is the main issue whenever you are tackling those patients. Before I believe that you come across this side of resistance bugs, you have to be very much cautious. These bugs also have some treatment, and the majority of this they will not follow the way you are thinking of, because there is an answer in today's days. Last 1 year we have been this ceftazimab, that could be an answer to this, but all BLBLI, they have a tendency to mutate very fast and faster, and they develop a cross resistance activities. First of all, very much cautious where you are using these drugs. You have to have a good microbiological backup to develop, and what is the MIC value, from where the collection, the sample collection is very important, whether you are basically treating a contaminant sample or you are treating a real bacterial threat. Basically, this is most important. Suppose a endotracheal tube suction gives you an answer of CRE. The patient is having only 25% of oxygen, and in the X-ray or in the CT scan, there is no chance of pneumonia. I believe this tracheobronchitis or tracheitis, I call in our ICU, this you should not give very much aggressive to treating this. Please be sure about this thing. What are you dealing? The main thing is that what are you treating for? What is the cause? It's not that only the numbers you are going to cross and give the antibiotic. Because you have to treat the syndrome. Try to put the patient is in a syndrome that these 3 points are there in favor of this. And these are the things. There is no leukocytosis. There is no other parameters. CRP, other things, they can be raised in any of the forms. If somebody comes with a head injury, they will have a CRP of more than 100. That is not the thing. I should start with the meropenem first. That's why my idea is, definitely this is an answer for CRE in today's days, but we in the next 2-4 years, 5 years, there is in the pipeline, there is nothing, a big antibiotic is coming. Very rationally, judiciously, you have to use your weapon.
Lots of insight there. What would be your message to the young generation ICU doctors, especially in enhancing patient care? What would you want to say to them?
No, it's fine. They are very good in whatever the struct, because when we have been taught in ICU, they were in the 25 years back. There was no formal structured program for Indian government to develop this. But the people who are coming, they're coming with a very good knowledge. They need to have a good exposure. The knowledge is not a problem in today's days, because the structures of Indian government and this medical education, they're very good, but they have not exposed to the certain amount of patients. It is our duty to make them expose, give the opportunity to flourish, and any other queries they do have, definitely to answer. You consult and you see what is the type of scenario. You give them some scenario and let them face this scenario. That will be the good option of growing them. But they are good people. I'm telling you, I'm dealing with the DRNB students, FNB students. They are very good in today's days. We never had this chance of at least giving this ourselves opportunities to growing up like this.
So I think that will be pleasing to the ears of the students if whoever hears this. What is the prevalence of carbapenems in your practice, and what are the treatment options?
I work in a tertiary care hospital, and that it's a referral ICU for all the ICUs, neurocritical care, then pulmonary critical care. If the patient are having really bad, they transfer to her. That's why in my ICU, the incidences of CRE and this are high, quite high. But I take this call very seriously when the CRE has been seeing what was the associated numbers, what is the site of infection, why the infection has occurred. If there is a source, you please control the source before you give the antibiotic. If there's a pneumonia with a pneumonic effusion, you have to drain this effusion, otherwise the source is there, whatever the antibiotic, whatever the mode you are using, it's not very much. First of all, and the next thing is very important, what is the duration of antibiotics we are using, what is the dose to dose variation, what is the renal status of the patient, how you can tackle the renal status with this antibiotic program. These are things that are very important when you are using such a big antibiotic and face them.
Loads of information from you, Dr. Roy. We thank you for your valuable time in our studio and we wish you all the best in your practice.